My name is Camilla Merrild, and I work at the Center for General Medicine at Aalborg University. And first of all, I want to thank you for giving me the opportunity to talk about some of the work that I've done within social inequality and health in Denmark. And I really look forward to the discussion that we're going to have online next week. My perspective or approach to social inequality is from the perspective of care seeking and experiences of the body. And geographically, I work in Denmark, which is a Scandinavian welfare country with a relatively high income level. And I guess from a global perspective, perhaps relatively low social inequality within the population. However, there are indeed differences in terms of life expectancy, quality of life, self-rated health, and so on. And social inequality is actually quite a big deal in Denmark, practically for healthcare practitioners, but also politically. And it's an area which is relatively well described by social epidemiologists who have, for many years, I think, painted a somewhat dull picture of differences in, for instance, life expectancy, and as you can see here on the screen, which is an image of the different income quantiles in Denmark. And I guess one thing that I hope to discuss today, or not today, next week, is statistics such as these, and I think they sometimes remind us of somewhat past anthropological discussions around categorization and generalization, where the argument is that it's difficult to theorize about group behavior and based on individual character traits. And of course, it's a general tenet in anthropology that biomedical and epidemiological categories are socially constructed rather than, of course, naturally given. It's nevertheless through the construction of, for instance, socioeconomic groups that they become real and available for interventions and actually enable us to work with categories or groups of people who are defined based on individual character traits such as educational background, financial statement, gender, housing situation, and so on. And in order to conceptualize social inequality in health, I guess we have to use these descriptions if we want to theorize about patterns of disease distribution, survival rates, and thereby engage with epidemiological studies of social inequality in health and illness. And one challenge is, of course, that we avoid, by doing this, is that we avoid talking about, for instance, class differences or hierarchies, and we sort of remain comfortably at the individual level of competencies, such as ability to live healthy lives, seek care early, and lead proper lifestyles, and so on. And then I will return to this issue later on in the presentation, I bring this up, I guess, as a way of introduction, because my interest in this area is probably strongly related with the context in which I work, of course, which is Denmark and Scandinavia, which is known for a strong focus on egalitarianism and universalism, and has an extensive social security and welfare system, which ensures free education, secures a minimum income for citizens who are not able to support themselves, and of course have this free medical healthcare system, which is organized very much based on the principles of universality and egalitarianism and so on. And I guess that particularly working within primary care, which is sort of the gatekeeper for the more specialized healthcare system, these principles are very, very much I guess forms the core of much of the professional identity, because when talking about approaches to social inequality within the healthcare system, this image that you see on the screen right here is very popular, and you're probably familiar with it. It comes in different shapes and variations with different arrangements of boxes and so on. But this particular version of the image is very is very popular within the Danish healthcare system, and reflect, I guess, the way that healthcare practitioners would much like to see their role in reducing social inequality in health, and their efforts to do so by providing more boxes and so on. But I want to say now a little bit about how I work with social inequality in health. And then my research, as I started out by saying, mostly focuses on the interface between people's everyday lives and the healthcare system, primarily primary care as the entry point. And I've been particularly interested in healthcare seeking and ways of moving from feeling fine to feeling sick, as Cameron Hay described it back in 2008, and I was very much inspired when I started out by the work of Cameron Hay and Mark Nichter and others who contributed to a special issue in transcultural psychiatry on the very notion of experiences of the bodies and sensations and so on. And of course, later on, I've also been very inspired by the work of Margaret Lock and all her colleagues on the work that she's done, of course, on local biologies and so on. So I have studied care seeking and experiences and practices of the body from the perspective of cancer diagnostics primarily. I've done field work among people who were living with cancer, people who were not, and people who lived at different ends of the social spectrum, from people who were leading very difficult and socially challenged lives, and people who were leading more privileged lives and were much more affluent. And I've also carried out studies in relation to health promotion initiatives directed at people who lived in socially deprived areas, who were considered vulnerable or at risk for developing lifestyle or chronic diseases. And I guess one thing that stood out in these different studies that I've done so far has been the insistent discrepancies between perspectives of health promotion messages or interventions and the perspectives or life situations or circumstances of those that we define as vulnerable or hard to reach or disadvantaged, or people with low socioeconomic position or status or what have you. And I think if we take cancer as an example, I want to try to sort of explicate what I mean by talking a little bit about how contemporary cancer approaches to cancer control are based on this perception, of course, that cancer can and must be diagnosed at an early stage in order to improve survival. And so in order to make people seek care at this early stage, cancer prevention messages all focus on what have become known as alarm symptoms, which are, of course, a list of symptoms that are defined as causing alarm. And so when experiences some of these symptoms for extended periods of time, people are expected to, or the idea is that people should seek care at their primary physician. And of course, such recommendations are based on biomedical statistics about how the normal body feels and how it should be experienced. But as Margaret Lock and others have shown, sociocultural environments and biology are deeply intertwined. So taking an example from my own work is, for instance, one alarm symptom is persistent cough, another is unexplained pain, and when thinking about the lives that my informants lived, or those who were living in difficult social circumstances, coughing or unexplained pain was part of everyday life, and not something that raised particular concern, because that was just the way it had always been, or that was the way it had been for the past year, and so on. So I have described this as living with noisy bodies, and this is very much the case if you have multiple illnesses, psychiatric challenges, social challenges, then the life and the body just makes more noise than the average normal body. And that, of course, influences how the body feels. And if we accept that experiences of sensations are embedded in both biological and social context, the concept of the normal body or when a sign or symptom should raise alarm becomes difficult to define. But early diagnosis, as cancer diagnostics are an example of, very much assumes this normal body. And it serves sort of as a standard of when to seek care and how the body is expected to speak of illness. But sometimes bodies are noisy, and ways of managing and experiences the body and interacting with the healthcare system does not correspond with official recommendations. And the people who are defined or described, or those who do not practice their bodies or interact with the healthcare system as expected, are often defined as or described as flawed, like coming too late and lacking competences. They don't know, they don't understand. And it leaves us with these very causal explanations of individual characteristics, which sometimes resembles a little bit of blaming the victim, and rather than discussing structures of inequality and structures of biological and social hierarchies and so on. In the context of Denmark and egalitarian welfare state, the way that I've been trying to think about this is through the concept of imagined sameness, which was developed by Norwegian anthropologist Marianne Gullestad. And the notion of imagined sameness refers to the way that social interaction and organization in Scandinavia rests on a form of social organization which actually upholds boundaries between social groups and simultaneously underplays differences and hierarchies by sort of surrounding yourself with people who are similar with yourself, trying to sort of downplay anything that could sort of indicate that the differences and conflict between the groups in the population. And I argue that in the discussion about sociology and health, social inequality and health in Denmark, this imagination has somewhat developed into an expectation of sameness in terms of ways of life, of practicing the body and utilizing the healthcare system. We have certain ways of expecting people to practice their bodies, and which becomes the standard against which we judge when they are not. So it becomes difficult to accept and let alone understand these very persistent social inequalities because they challenge the very core, I guess, of Danish self-understanding and identity, and which is shaped of this notion of imagined sameness, a likeness, a homogeneity. And I guess this is where I'll end it today, and I very much look forward to discussing with you next week. And yes, I will see you all then.